Okay, good afternoon, everyone. Thank you so much for joining us today. My name is Lori Marie Peixoto, and I'm the Executive Director of the Mental Health Association of Rhode Island. We are very excited to hold our first ever virtual town hall. Today's topic, as you know, is racism, equity, and mental illness. And we have a wonderful panel of community leaders here with us to discuss this topic. First, I'd like to introduce Dr. Ernestine Jennings, who is a staff psychologist at the Miriam Hospital and an associate professor of psychiatry and human behavior at the Warren Alpert Medical School of Brown University. She's also on the Mental Health Association's board of directors and has been instrumental in our research projects, including our recent white paper, which was released today. We also have Sandra Victorino. Sandra is the Director of Acute Care Services at the Providence Center, which is a community mental health center, and she's co-founder of the Latino Mental Health Network. Sandra has worked in the mental health field for 15 years. Her areas of interest in healthcare are access for minority populations, health and mental health equity, and culturally and linguistically appropriate health services. Also joining us on the panel, we are very lucky to have Larry Warner, who is co-chair of the Rhode Island Commission for Health Advocacy and Equity, which monitors the status of health disparities and provides guidance to state and community stakeholders to promote health equity in Rhode Island. Larry is also the Director of Grants and Strategic Initiatives for United Way of Rhode Island. He is also a candidate for a Doctor of Public Health degree in Health Equity and Social Justice at the Johns Hopkins Bloomberg School of Public Health. We couldn't be more excited to have the three of them with us today. And with that, let us begin. Just a few housekeeping notes. Audience members, we will take your questions at the end. As questions come to your mind, please feel free to write them, type them into the chat box, and then we will we will pose your questions to the panelists at the end of our discussion. We will begin, and I will ask each of the three panelists a question. Each panelist will have a turn to comment, and then if we want to have a little bit of crosstalk, you're more than welcome to do so. Our first question is, just establishing a foundation for this discussion, what is systemic racism? And if you could give one or two examples, I would encourage panelists to approach this either from an academic or research perspective, or if you would like, from personal experience. Dr. Jennings, can we begin with you? What is systemic racism? How would you define it for people?
Yeah, so I would define systemic racism as so when we're thinking about the practices that are amongst institutions that stay in play, that actually reinforce stereotypes and actually can impede people's progress because of their nature in which they are racist. So understanding that it's not just, I often talk about, it's not just preference or, you know, what you like, it's how those impede or impact, those practices impact a group of people that reinforce negative stereotypes and or beliefs in a systemic way. So examples of that, I'm thinking, you know, broad examples are like Jim Crow, right? So that was a systemic practice of segregation that impacted people in terms of where they could even sit, eat, right, drink. But also people believed that, you know, maybe another group of people was not able to do certain things simply because of, well, I don't see them here. Well, it's because they can't be there. So that's one issue. The other one I was thinking of is like redlining. And redlining is where you had actual districts drawn where people could not buy houses, right? And so African Americans weren't even offered to look at certain houses and couldn't live in certain areas. So that ended up with them being placed in certain areas that weren't maybe not the best areas, because they were not allowed to purchase homes in certain parts of the city and or town. And so those are, that would be a systemic practice. So I'll let others, I know there are many others, so I'll let others go.
Sandra, would you like to provide your own definition or elaborate on what Dr. Jennings has already shared?
So I think she said it very beautifully as far as the systemic racism, the definition. And I was actually, redlining was going to be one of my examples. So I guess I see the component of, not being able to obtain those loans. And that's one of the things that we can add to it, to be able to live in those areas, or only allowing so many to be in a certain area, and so not allowing others. One of the examples that I guess I would use, and what I see a lot of clients in mental health and, people that I mentor and coach, is that we, as people of color, we don't have an understanding of our own story. And I see that as a systemic problem within our educational system. So when you go through, for myself, I went to 10 different high schools before, 10 different schools before I graduated from high school. And I went to 3 universities, and never once was there a very conscious decision by any of those educators to have these conversations about systemic racism. So you have a lot of people that are walking around without their own story, which in some ways you can't understand it other than being intentional or not being part of someone else's existence. So that I see that a lot with within our education systems in public and state institutions. And so that's something that we have, I have looked at with people in our community.
Thank you, Sandra. Thank you for sharing your own experience as well. Larry, would you like to comment on what Dr. Jennings and Sandra have said, or provide your own definition of systemic racism?
Sure. I would add on to the great examples that were already given by saying that when you think about the impact of redlining and discriminatory practices in loans, and even how the Fair Housing Act was not equitably implemented decades ago, that has long-term impacts on how neighborhoods are shaped, what they look like, and the experience of people in those communities. Because when you have the accumulation of wealth or the concentration of poverty in certain communities, think about what the impact is to the tax base and what that means for investing in schools and other infrastructure. And then the downstream impacts of those are the types of trauma that we see resulting from poverty, resulting from food insecurity, and a lot of the things that we see as needs in real time in the moment, but we don't necessarily think about the root cause because of systemic racism that's been implemented over several years, several decades.
I think what really striking to me is how systemic racism that occurs decades and decades in the past still has this ripple effect and echoes into the present. That it's, it doesn't just harm one person, it harms generations of family members over time.
I think it's important, as Sandra said, is to understand the story. I think one of the things that happens is we don't tell those stories, right? We don't talk about why there aren't people in the halls of a medical school with pictures that look like me. Like, why is that not happening? And so I think beginning to tell those stories and understand, talk about redlining in the context of not only education, but, I don't know, during your orientations, when you talk about why certain groups might not be, I do research, and one of the things that I talk about when I'm just interacting with different groups is understanding why might a group of people not want to sign up for my study that theoretically looks like it's helping the community, right? Well, guess what? There's been a time when there were studies done on people of color, and that's I guess, in terms of healthcare, when we talk about those experiments, and recognizing that it brought a distrust within the community, the African American community, that ripples to this day, to the point of the speakers saying that, this is not just something that happened last, one study, and we have, with Henrietta Lacks, we have the Tuskegee study done with syphilis. And while those studies were done many years ago, and even with Henrietta Lacks, we learned more recently, when I go to recruit people African Americans, they will tell me, now look, I know what this is. I know what happens when research happens. I'm like, oh my goodness. So not just the laws that are in place, but actual things that we've done in our history that have systematically been implemented. It was, a national study. It was definitely something that has impacted people currently when we talk about healthcare and health delivery or delivery of healthcare.
I invite any other comments from Larry or from Sandra before we move on, or?
I would just add to the healthcare context that there certainly is a lack of trust in healthcare institutions because of past experiences, historical experiences, and present day reality. There's a significant proportion of minority groups that feel or have articulated that they've been discriminated against in healthcare settings. Studies out of Harvard have quantified it. I think it was roughly 25% of Blacks and Hispanics in that range. And so there are still experiences that people have that not only impact how they're communicating or not communicating with their providers, in addition to the systemic barriers, whether it's around lack of access due to cost, or lack of access due to the number of providers and the geography. But there's certainly a lot that needs to be tackled in order to support equitable outcomes and have a quality experience with your provider.
So I would add to it by just saying that, we see that by the lack of representation. And I think that in itself for our communities, that's one way that we can start establishing trust, but it's not enough. And so you continue to see it. And so as people continue to see certain things, they continue to stay away. And so I see that as a barrier for our healthcare system. There are some people that are having more intention in diversifying or doing such things. But we're at this point in 2020 and we're having these conversations. So it's a long road ahead.
Thank you. Thank you. How does living with systemic racism over a lifetime affect one's physical, mental, and emotional well-being? What are the effects of that? Do you consider systemic racism like a trauma? Is this a trauma that people are living with on a day-to-day basis? Dr. Jennings, do you want to tackle it first?
Yeah, no, I'm happy to rotate. I feel like everybody has, we know that, yes, it's trauma, but it's the impact of lack of appropriate care, the impact of being thought less than. Those are all on a psychological basis, but also when we talk about health, we know that, well, in terms of a stressor. So yes, the impact of, worrying about what people think about you, if you're going to be able to work today, all those things have an impact on your health and safety of your neighborhood. All of those things have an impact on your health. It can increase cortisol. We talk about that, biomarkers related to stress. Increased cortisol is not good because it's related to weight gain. We are seeing that increased incidence of self-reported racism impacts people's sleep. Just things that your day-to-day living. So just, and by if you just watch the news, right? Just by walking down the street, trying to watch birds, there's all these things that can happen just in the context of your day. So I don't want to say it's because a person's race, but it's the impact of the things that they experience in the context of being that person. Yes, can impact a person both psychologically and ultimately their overall health profile is impacted by the experiences. And we see this, a lot of people will say, well, yes, people in poverty, they experience this stress. But we have looked at the data when we pull out controlling for poverty, both Black and white people experiencing the same experiences, we see that those people who are Black actually experience worse outcomes. And maybe people who are white might even have a protected or a null effect. And it's like, okay, something is going on here. So that's where we start to say, okay, there's a difference. It's not just poverty, because that's not good, but it's the impact of being impoverished in a neighborhood and not having opportunities to do certain things.
I would agree with that fully and say that the data does support that race does exceed what people would assume education and socioeconomic status contribute to one outcome. So when you control for education, for socioeconomic status, you still find that Blacks with a college education tend to have worse health outcomes than a white person with a high school diploma on average, because there are stressors that you can't capture in those other demographics that are experienced solely because of race. Part of it is experiential, part of it is exposure. And I think that, I can't take credit for the analogy I'm about to give, but I heard it on the United Way network recently, where if you compare repetitive brain trauma to the impact of racism, it's not, if you think about the injuries that football players experience, it's not necessarily the one big hit that's going to cause you to have CTE, but it's those little hits over time that repeatedly injure the brain, and over the long term will cause cognitive decline or other injuries. Similarly with racism, yes, there may be major incidents that have a long-lasting impact on one's well-being, but it's those repeated exposures, those microaggressions, the experience of people crossing the street, or you being followed in the store, or you being denied a job because of the sounding of your name. Those are all the things that add up and contribute to long-term chronic stress experienced by people of color that isn't necessarily captured in other ways that we measure mental health.
Yeah, I agree with everything that's been said. And so for me, I just always think about how it prevents or makes it more challenging for us to participate in it. So I know, like, I always talk to my clients about, Maslow's basic hierarchy of need. And so when you think about all of this, is how does that impact people every single day? If you go down the list of those hierarchy of needs, or if you go through William Glasser's basic, choice theory, basic needs, like those are all things that end up impacting people every single day. And, I think about how it impacts me, and I don't have the same impact that others that are people of color that they have. And so it's all, and I think one of the things that I always talk about is diversity within diversity, because those are things that we don't take into consideration. And every diverse experience is different. So it's just important to take those things into consideration. The most important part is with Maslow's hierarchy of need is how do we get into that self-actualization stage if we don't have all of those other things? And how much longer is it taking people of color to get into those self-actualization stages when we're kind of trying to figure out all those others to begin with?
Absolutely. And I think in the context of delivering care with people, it's understanding that too can be, it's not just the person's context that they come out of, but like the belief of the provider in front of them, right? So we know that certain people are less likely to be offered pain meds because of the color of their skin. Certain people are diagnosed with different diagnoses because of the color of their skin. I've talked to people before where we've seen the same, you see the same set of issues that come in, and maybe my interaction with the person or perception of what they're dealing with is different than what they will say. And I will say, explain to me why you did that. Well, it says right here in the checklist. And what they're counting as something like maybe paranoia. So one of the examples I used to give is the idea of someone saying, they're paranoid that people are watching them. And they're like, yeah, this guy was talking about he's being followed in a store and da-da-da. And I'm like, what did that person look like? It was an African-American man was telling me about how people follow. I'm like, because possibly people are looking at him that way. But why would he, and so recognizing that providers, not oftentimes, but sometimes can put on to a person, well, and downplay a person's experience. Well, you can't be feeling that pain. The belief that, certain people don't experience pain at a certain level, or are drug seeking. Like, those are the kinds of things that can also impact a person's outcome in terms of the care that they receive.
Adding to that piece, one of the things that I think about is what we also take away when we don't understand. And the spirituality, and what each community has to hold on as far as for strength. Sometimes if the provider isn't careful, they take that piece away because we don't understand the structural racism that can exist. And so we leave the individual or the community member or the community itself abandoned of what the resource that they would use in order to hold their own strength.
Absolutely. Meeting them where they're at and recognizing that. I think I've worked in a lot of different communities. And one of the issues that I've learned a lot about healers and what people consider to be a healer. And we have to acknowledge that, and we have to honor that. And that's just, like I said, just trying to, in my role as I believe as a mental health care provider, as part of their healing team, how do we incorporate those things as well? And I don't know that that's something that's done so often, but we're working on it.
We've touched on this a little bit, but I want to dive into it a little bit further because this was one of the things that came up in our recent white paper report that we just released. When people are trying to access behavioral health treatment, they're often met with obstacles. For example, obstacles placed there by their insurance company. But what additional barriers do people of color face when they try to access care? Can you talk a little bit about perhaps stigma or, the difficulty in finding providers that one can connect with, or language competency? Because there are a whole host of additional barriers that people can face in not just in Rhode Island, probably everywhere. But can you talk a little bit about that, Dr. Jennings?
Yeah, so I think, as we noted in the study that we looked at, we asked people kind of what were some of the issues that got in the way. Language was clearly one. Cultural stigma, understanding kind of what mental health and what that's all about, and how it's perceived in their cultural background. Also, maybe the setting is not set up for, I talk about, like, my first meeting with a family for one person. I said, and bringing in the whole family, and grandma's coming, and recognizing those kinds of things happen and being okay with it, rather than, confidentiality, it's important, but it's also, we want to be able to have some interaction with the patient. So being able to do that. For me, I have several Spanish-speaking patients. I don't speak Spanish, so understanding the limitations to having an interpreter in the room and or on the phone, and recognizing some of the issues that have to be dealt with. And even if I do have an interpreter in the room, recognizing that dynamic as well. So there's, I think, many things that I think need to be addressed. And I think coming from the perspective that I've talked a little bit about this equality versus equity, making sure that we provide people what they need. Like, everybody, what is it that needs to happen so that that person can receive the treatment that they need, and that I, as a provider, am doing that competently. And that may be a different setting. It may mean 2 or 3 more sessions about certain things so that they can understand. But I think sometimes we get caught up in having to do it the same for everybody, and that's what I'm finding is not the case. In terms of barriers, I'm sure. Sandra. Yeah.
Thank you. So, I mean, I think about, I being a bilingual, bicultural therapist, it's one of the things that I see all the time, but, I never took into consideration what it would be like not being on that side, as Dr. Jennings just explained. And so in Rhode Island, we have a very diverse community in many languages. And I think that that's one thing that we don't take into consideration often enough. So and when I'm thinking about access and health outcomes, I'm thinking about how are we helping our young bilingual, bicultural students really go down the pipeline and to be able to provide treatment for their own communities. We lack that within our, the African communities, our Asian communities, and I think that being such a large refugee state, I didn't really recognize. And when I first moved to Rhode Island, it was one of the things that I really started to value and love about it, in the way that we have such a diverse community, but we really haven't done the support system for that diverse community. So finding providers that can really understand the culture and allow people to feel safe, because there's gatekeepers to each community, and how do we and healthcare end up helping those things. So I think all of those affect our outcomes, especially when I think about us locally here in Rhode Island, and how do we support and help that.
The only thing I would add is just echoing the importance of access to diverse and culturally competent providers is huge. It helps to facilitate trust and understanding between patient and provider, and some of the barriers that are experienced by immigrants, people of color, the uninsured, and I'm not lumping them all together, but these are different subgroups that experience similar challenges, are around access, geographic, culturally competent. I think that we have seen a lot of progress in some of the integration of behavioral health with primary care, which helps to increase access and not make it a separate other thing that people are thinking about with respect to their health. And I think that's huge, to think about the whole person and not from the neck up and from the neck down. But there are still issues of stigma in communities of color, and that mental health is not something, or mental health care is not something that's often looked at as acceptable to seek, even when it's clearly necessary. And so I think that by building up trust and accessibility on the system side, and then meeting the community where it is with its acceptance, and understanding that there's a history of trauma there as well, that I think we'll continue to see progress and gains in how communities of color are accessing mental health resources.
On the flip side to what Larry's point was, the fact that our providers sometimes don't understand that there is that stigma within the community, and instead of addressing, figuring out how we can, break down those barriers, sometimes we end up calling this I've heard a lot of people say that someone's difficult or doesn't want to engage, and so using those judgmental statements and holding that judgment for certain communities, certain populations, in that we see why people don't want to engage or have the outcomes, because we're coming there. That's the perspective someone's coming from. So it's just being careful and intentional, and I think it's continuing to educate the providers that are in those roles right now.
And I always encourage providers to become part of the community, whatever community that you are in, because I think, as I said, I've learned wherever I go, I don't know, maybe it's because I was raised in the military, but wherever I go, I've learned to, learn who you're around, learn the group of people, their customs, what they, what their expectations are. You're visiting, and I feel like with my patients, I am, especially just in the session, I mean, I truly feel like they're inviting me in. And so I want to honor that. And I don't, yes, I bring some expertise. However, they're an expert on who they are, and I'm learning from them. And I just encourage people, like one of the things that I've talked a lot about is, learning, making sure you're open and learning from I learn way more from my patients than, I mean, maybe every now and then I facilitate some change, but like most of the time they are working hard and recognizing that. And I think a lot of times just coming with that spirit to the encounter is important, but I think you have to learn before you go into the room with them. I just can't imagine that it's not their job to educate me. Like I should know, like I worked on a reservation, like I should know the different tribes and like, who was the chief at least 2 times ago, so that when they start talking about that history, I can go, oh yes, you know, that did happen. I don't know the third term before, but I'm working on that. Like, but those are things that to honor their community. And I just think sometimes that's a barrier because we come in, oh, you tell me everything. And then I'm going to learn all about, you know, your church service because you're going to tell me about it versus I could probably look up once you tell me, you know, what kinds of things you do. I'm going to make sure I, you know, understand you guys meet on Saturdays, not Sundays. I can get in that, like different things like that. And make an effort.
Thank you, Dr. Jennings. The last question I have planned for us before we start taking questions from the audience, and again, audience members, I welcome your questions. Please feel free to type them into the Q&A or the chat box. But can we talk a little bit about some action steps that we, the collective we, can take? So I've been reading a book by Ibram X. Kendi called How to Be Anti-Racist. And in the book, he writes, the opposite of racist isn't not racist. It is anti-racist. And to me, that means it's more about taking action than it is just a state of being not racist. What can we do, especially we, the white majority, what can we do to help end systemic racism in the various facets of our lives where it occurs, housing, education, healthcare, but what are some concrete steps that we can take to help and to end this?
I'll let you all start.
So I'll go. You know, to me, it's just acknowledging that racism really exists and being aware that that is something that is there. And then, you know, if you really want to fight it, finding the organizations that are doing the work and joining them and helping. I think that those are some important things to say. And I have another, but I'll let Dr. Jennings or Larry go.
Larry.
Happy to jump in. I would piggyback on the notion of educating oneself and acknowledging that structural racism is a real thing. I think largely as a country, we're still in denial, even though recent racial injustices that have been televised are removing the curtain a little bit, but we still have this sense of, no, that's really just a small proportion of the community that acts a certain way, or a certain number of people of color that have had bad luck when it comes to applying for jobs or for housing and things. And it's really not, what we're probably seeing is the tip of the iceberg, really. And that there's so many other facets of our society that are made more complicated for our communities, but really harming our communities because of structural racism. And that the disparities that we see, and I would add to, in addition to education, is measuring the right things and understanding that when we see disparities in housing and in DCYF and in healthcare, the root cause underlying all of these disparities is structural racism. And so once you've educated yourself and you understand where structural racism is manifesting itself, you have to act, engage in within the sphere of influence that you have to tackle the systems that are propagating and establishing or propagating barriers to opportunity for communities of color that have been experiencing discrimination and racism for hundreds of years, but to the decades that we've been alive. Know that there's an advantage that everyone has, particularly white people, and so using your advantage to betray the systems that are establishing and maintaining barriers.
Absolutely, those are great. One of the things I think in addition to the structural change that you can go out is also self-reflection. I think I talk a lot about, it starts with you, and we can go out and do all these things, but I think understanding what scripts do I have internally about certain groups. I often talk about my aversion to plaid and stripes together. People love it. I'm learning. However, when it affects someone else's ability to dress, that's a problem, right? When I start saying to people, don't show up unless you have, all black on, that's a problem. And so recognizing that, what I believe can have an impact, like you say, if I had a trainee and I say that out loud and they're like, all I have is stripes and plaids, what do I do? I can't change my wardrobe. I don't have a ton of money for clothes. Like, and I know that makes it very basic, but I think sometimes when I talk, people think, oh, I've got to go and do, and I think getting involved and doing all these things is wonderful, but I think start with what scripts do I have? Because when you show up and still have those ideas, it comes out. And that's, and then, okay, so say you reflect and it still comes out. When it comes out and someone calls you on it, be humble. Say, you know what, you got me. I still have this image of less than for a certain group of people, or I still think I'm here in the capacity as a learner, and I've taken over and started, becoming the teacher. I gotta check that. So being, and that's work. I know it is. I'm not saying it's easy, but I think it's, if we say that we want to address systemic racism, we need to make sure that those are the things that we're doing on a, when we're engaging in these different communities, and start with ourselves, and then be, humble when we go and actually engage. And, someone might, like I said, someone might say, no, that's not right. And you're there to learn, you're there to make change. And if you, like I say, if I'm, as long as we're going in the same direction, that's the goal. So show me so that we can get there together.
Okay, thank you so much. I think we'll take a few questions from the audience. We have several that have come in. The first one is Michael, who is a local psychologist, writes, I work in a predominantly white mental health practice, and I would like my workplace to diversify more in terms of racial and ethnic identity. I have two questions. First, how do I convince organizational leadership that diversifying the team should be a priority when hiring new staff? And second, what kind of recommendations do you have to help retain any newly hired people of color in a predominantly white workspace? Two great questions. Anyone can feel free to jump in and take a shot.
I'll start. So I think diversity should be seen as a way to not only strengthen the organization that's delivering a service, but also to better serve and be better accessible to the community that you're serving. The ability to relate, to facilitate trust and communication with your client, with a patient, with whoever you're serving, can only be improved by having multiple perspectives, multiple experiences, multiple backgrounds on your team. So, and that's before you even get to the clinical realm of care delivery. And I'm going to trust that Dr. Jennings can flesh that out a little bit more based on her experience and background. But I know that having worked on healthcare access over a few years, that there are needs that providers have that will attract them to a workplace and to a state for that matter, and that will help retain them or drive them away. And there are financial incentives. There's the context, the cultural context, and cultural intelligence of organizations that they come and work for. And if you find a rock star who comes to work for your organization, but they come into an unwelcoming, non-diverse, non-culturally competent setting, they're not going to last there that long, no matter how good the money is. And so there has to be an environment that's welcoming, a professional network to support and see other professionals that look like them, or can understand their experience, and then look at what are the incentives that address real needs, and whether it's loan repayment or housing, money towards housing. I don't know the full gamut of resources that can be deployed, But those are some of the things that I know different providers have employed to help attract and retain providers of different backgrounds.
Thank you, Larry. Another question is,
Oh, Sandra, did you have something?
So one of the things that I would add to that is making sure that there is, so bringing one person in, as Larry was speaking about, you know, that it's not just that one person, it's making sure that you have the support system. I think about it a lot as a village, and that's how I talk about things, because in a village you have, when we think about villages, we have these generational differences, right? It's all intergenerational and people are providing each other support. And that's very similar to when you're providing care. So if you have a case manager in the sense of community mental health center, you have a case manager that's Spanish speaking, bilingual Spanish, and you have 5 therapists that are bilingual, bicultural. Well, and each therapist has 80 clients to their caseload. You're dumping all of that onto one staff member. And so those are things to take into consideration. You know, and then making sure that there are services in the community that really are going to help those clients. So as a mental health therapist, and I had to learn everything that had to do with substance abuse, because I was the only one that was able to provide that service. So I had to learn more about substance abuse than my other peers that were monolingual. And so I was the one that was providing all of that care. So now I have this caseload, but nowhere to refer to in the community. So there's no residential programs that are Spanish speaking. So that weight goes onto that one provider. So if we think about it in that context, people get burnt out really quickly. So even when we're trying to diversify and we bring one person in, we need to make sure there's a support system and that we continue to advocate outside of our communities, not only just our workspace, but that we're doing that work outside of our space.
Absolutely. Agree.
any other comments before we move on to the next question? Okay. Alexa is asking, what types of mental health education should we be implementing in K-12 programs, and when exactly should we start them? Meaning what grade or what age?
I say birth. I think there's a way that we can teach people about their mental health from birth. I think the way that we talk about our feelings or don't is picked up by kids. Their goal in life, like the minute they're born, they're born learning you. And so they learn, we don't talk about this, we talk about that. I get breakfast, I can have chocolate cake for breakfast with dad, mom, have to wait till 3. Like there's things that they learn. So I think it's never too early. I think ways to help them understand how to talk about their feelings, to understand what's going on in their body. It doesn't have to be a whole, conversation on, well, I guess it'd be a short conversation about tell me about your life so far, but it can be something as basic as just helping them understand when they feel happy, when they feel sad. And that can start it from an early age. I think continuing to do that along their life's journey. And I see that in certain situations where people have done that. And it's an interesting conversation when a child comes up to you and says, I feel, that feeling in my pit of my stomach when I feel angry, I just want to let you know. And you go, what? But that's, them expressing and teaching them how to express. I think it starts very early. And I think continuing to do it. One of the things that my colleagues and I talk about, like you can share information with people, just what's the amount of information that you need to share. So with kids, understanding that they can comprehend certain things at a certain age and then build on that rather than dumping everything on them. There's certain things they can't carry. And that's one of the issues that I guess I have sometimes when I'm working with a family and they bring a child in for interpreting. I struggle with that because I think there are certain things I can't say. I wouldn't ask the child to ask their parent. And not because maybe they do that with other people, but I think in the context of the interaction, it's not the right thing to do with a child. And so that's an issue that I think understanding like when to cross certain content is, but otherwise I think starting young.
I agree. I mean, I think that there's no as soon as you can start having conversations, and children understand and see everything. So it's,
Yeah.
I mean, you see them, if they're understanding some of our other behavior, they would understand this behavior as well.
But like soothing techniques, you can teach
Yeah.
baby massage, like, you know what I mean? Like, and training a child how to self-soothe, like what? Like, that's awesome.
One of the things, I predominantly work with adults, and so one of the things that I used to do a lot with the mothers when they would come in with their babies, I would encourage them to bring their babies in with them, because we're having conversation, and it was monitoring their breathing and their heart rate, and practicing that deep breathing while they're holding their baby. So, and I'm like, this is, your baby's also learning this. So it's those kind of strategies, because I think we also have to look at the context of how our sometimes our community is living, and you know, sometimes there's no childcare. So yes, how do we incorporate this into your care? You know, there's going to be moments that you're going to have to figure out how to take it apart, but I think that's also having that, helping with those healthcare outcomes. I think we've had very linear ways of thinking about, you know, bringing a child in or not bringing them in, and if they have to be there, how do you make it work instead of turning the person away?
Absolutely.
I would just add that I'm glad that question came up, but it forces us to think about what's the balance between academics and social and emotional learning that exists in our educational system. And, you know, I fully agree that it needs to start at birth, but I think in reality, in K through 12, my sense as a parent with kids in that age range is that it's often an afterthought, that it's really about test performance, grade performance, but not so much the social and emotional development of our youth. And so I think there needs to be more of an emphasis on that. And I think that that's an area where we've seen a lot of success in after school and summer learning programs, because while there's an interest in supplementing what's going on during the school day, there's more of an opportunity to provide enrichment activities and foster social and emotional development that there's not necessarily the time crunch in the traditional school day for. So I think more opportunities to support youth emotional development. And then the last thing I'll say on this question is, specifically because I'm a male, that it's important to teach young boys as they're growing up healthy masculinity, and how to deal with their emotions and how to communicate them, and the falsehood that real men don't cry or real boys don't cry, that is so damaging to how anybody, but particularly men or boys, because that's who usually is hearing it. That's really damaging to boys and men as they grow older. And so addressing that early on, and making sure that our youth know that it's okay to cry, whether or not you know why, whether you're physically hurt or emotionally hurt, it's okay to cry, and to work on communicating your feelings so that you don't get bottled up and turn and develop toxic characteristics.
Great point. We have a question here from Senator Cicilline. He asks, have there been noticeable differences between Black men and Black women in terms of receptivity to mental health services? Also, what do we know about insurance coverage for the Black population versus the white population at places of employment?
So I can't speak, I'm speaking, I guess, from experience, and then I guess data-wise, we know that Black men access therapy less than African-American women. I don't know to what levels, because again, I don't have the data on that in front of me, but in terms of the noticeable difference, I think also can be attributed to the rate at which they receive healthcare, period. And so understanding that Black women are more likely to reach out for healthcare versus Black men can impact that. Alternative, as we talk about insurance, I'm thinking about certainly in terms of the type of jobs that the African American or Black population is more likely to have than the white population, that likely impacts the insurance coverage and or the rate of insurance coverage or what's covered. And so we have been working to understand, parity, so that it is, if you have coverage, these are the things that are, and understanding what you have access to. I've had people who have said to me they didn't know that they could talk with a psychologist, but they do go to their annual visit to their PCP every year. And so it's like, actually, you can, and these are the things that you have. So even if they have insurance coverage, how much do they know about their mental health coverage in that insurance, I think is an important factor that we're looking at and are seeing that there's a difference in people's understanding of what they have access to.
So I will speak to the insurance component of it. A lot of the staff that I've educated when having their insurance coverage and having access. So we have first generation. There's a lot of first generation professionals that don't have the awareness of what they, back to Dr. Jennings' point, what they can or cannot qualify for. So there's a lack of understanding on that. And there's not a lot of people within organizations sometimes that understand that educational piece has to happen with first generation professionals. I think we expect people when they come into a profession that they're going to know what they can or cannot have access to, or that they have a community that they can pull from. But as a first generation professional, you really don't have access to that unless someone has been there throughout the steps with you, and that you have the confidence and the esteem to ask that question. And then the other piece is that we think about some of the first generation professionals, they end up providing not only care for themselves, but for their families. So their income ends up going to many different components. So they might get a lower rate insurance instead of the higher rate, and then not go and get treatment for something because they're out of coverage. It's one of the things that I have had conversations with some of the individuals that I've met with, or when they have to switch insurances. So my insurance company now is switching into another provider, and my providers that I had no longer take that insurance. Well, as someone that doesn't have much confidence or esteem that other people, but I met this one provider and I can talk to them now, and now they don't take my insurance coverage. I have to now find someone else, especially if it's a person of color that you're seeing. You have to now go find another person of color that's a provider, and that's not very likely to happen.
I would just add and echo what was said about the design of benefits, the jobs and the benefits that they bring, health literacy, which is that you could spend a whole nother session on the impact of health literacy on navigating our health systems and benefits as well. But also, and I don't have the data right now at my fingertips, but my conversations that I've had indicate that there's a significant number of providers that only take self-pay. And so even if you have coverage, the ability to find a provider that's taking that coverage is a challenge, let alone find someone who takes that coverage and is culturally competent to provide care that's going to meet your needs. And so there's a whole host of contributing factors around access. Even when we design a system that we think will work well and integrate it with primary care, there's still other access barriers to be addressed.
Thanks, Larry. One more question. Albert writes, COVID-19 is an added stressor, and data show that Black and Brown people are being disproportionately impacted. What policies do you think can be advocated to address racism in the era of COVID-19?
That's a very packed question. So I know that there's a lot of need that has been highlighted because of COVID-19, and a lot of need that has been created by COVID-19. There's a lot of communities that, because of the public health need to be socially distant, have become emotionally isolated, and that has unfortunately worsened some the mental well-being of individuals and communities. That being said, I think I don't have an easy answer other than as we start to reopen the state and as we think about what systems need to exist in a different configuration that meet the community's needs, not only on a care delivery side, but also on the systems that are creating the context within which we live. Um, all of the challenges that we've talked about over the course of the town hall, whether it's housing, whether it's healthcare access, whether it's food insecurity, these are a number of resources in the community or policy areas where if we make the right investments and the right decisions, we can create more resilient communities, and more resilient communities will facilitate and promote better mental health and well-being. And if we miss this opportunity to rebuild systems with a racial justice lens and with an opportunity to turn course from where we have experienced what we have seen as racially unjust policies, if we miss this opportunity, then I think we'll unfortunately see the same outcome the next time we have a major health crisis.
Thanks, Larry. I see that we're approaching 4 o'clock. I would ask each of our panelists, do you have any closing remarks or anything you want us to ponder, or any final statements from each of you? Words of wisdom?
I guess my only last thing to say is that we just need to make sure we continue to elect leaders and policymakers that are going to be able to make these changes. As Larry pointed out, I mean, there's a lot of things that we can do differently right now. And with this opportunity to create change and really implement the right steps in order for our communities to be able to benefit in the best way possible. So I think that's something to take into consideration at this point.
And I just want to say, I want to encourage people to continue. I feel like maybe people felt like maybe this is a little heavy to talk about, but for me, I think I'm so energized. These are conversations that I've been having many, many years, and we all have. I didn't start.
Yeah.
Yes, I just want to encourage people to use their energy to make that influence where you are at. You know, one of the things I talk about is like grow where you're planted. And I feel like sometimes we're out, we go looking for things we can be involved in. But if you just look around, you have the opportunity to make some change. I just encourage you to continue to look for those opportunities and be energized. As Sandra's saying, this is an opportunity. This is people started out many, many, many years before me, and there will be people many, many years after me. So what seed can you plant now and grow where you're at? And I think you'll make a huge difference. So just continue. I just want to encourage people to continue.
I like that. Grow where you're at. Larry, any final thoughts from you?
I would just echo what my esteemed colleagues on today's call have said, and as far as being engaged, circling back to earlier in the conversation, introspect and see what work each of us needs to do within our respective circles and spheres of influence. And then as the opportunity presents itself, like we have this election cycle, be mindful of who we elect as the next leaders in our cities and towns and state and federal government. Be counted if you haven't already in the census, because being counted is important for allocation of resources to help address some of the structural needs that we're talking about today. And then keep the conversation going. And thank you, Laurie, for hosting this conversation and having us be part of it.
Thank you, Larry. Thank you, Sandra. And thank you, Dr. Jennings. This was really enlightening and interesting, and I hope that the audience enjoyed it as well. We received so many comments in the comment box. I'm sorry we just don't have time to get to all of them today, but we will do this again, and we will continue to explore this subject of systemic racism, particularly in Rhode Island and in our mental health care system. Thank you to our panelists who took time out of their very busy days to be here to share your experiences, to share the information. We really appreciate everything that you've talked about today. I want to thank the audience also for your great questions. Please sign up for the Mental Health Association's newsletters so you'll know when we do another town hall. And thank you very, very much to everyone today for this call. Stay well, everyone, and thank you again for the wise words.